Hello, today we will be discussing in this lecture polycystic ovarian syndrome. Sometimes it's also referred to as Stein-Leventhal syndrome, in memory of these two great gynecologists who describe amenorrhea associated with bilateral polycystic ovaries in 7 women. So they wrote a paper that actually brought clearly about these conditions. We need to know that it is an heterogeneous multisystem endocrinopathy in women of reproductive age that leads to chronic anovulation, resulting into infertility, irregular uterine bleeding, and then obesity and asceticism. Much as we talk about obesity here, we also need to remember that some women are actually lean, but they have polycystic ovarian syndrome. Of course, it is the most common endocrinopathy, but least understood. It's the endocrine excess is because of the androgen excess. Of course, in 1935, these two gentlemen, Stein and Leventhal, described that, and it was referred to as Stein-Leventhal syndrome. As I said earlier, if you look at this is a normal ovary. See the follicular distribution is very normal. And then you see in a polycystic ovaries, at the periphery, you see that there are pits, and these pits are actually follicles. These actually are follicles that has grown and it has stopped growing. And that's what brings about the polycystic ovarian morphology. In some literature, people also call them Ayer-Ann syndrome. The Ayer-Ann syndrome means that the woman has hyperandrogenism, and this androgenism is because of insulin resistance. And then also this insulin resistance can also cause acanthosis nigricans. Acanthosis nigricans is a thick, leathery appearance of the skin of the neck, and it's darkening. It presents in various forms. These 10 various forms in which polycystic ovarian syndrome can present. It could actually have, you can actually have balding. You can also have absence of menstruation. Amenorrhea can result that, or irregular period. Or sometimes the period is even too much. You could actually have excessive body hair, and then you have abnormal skin discoloration, as we talked about. It could also present in weight gain, and then other various forms, of course, depression, stress, and then high blood pressure, then too much pimples. The pathophysiology is not completely understood, but the main candidate is actually insulin resistance. It has been shown that 57% of women who have PCOS actually have hyperinsulinemia. The cause of this hyperinsulinemia is completely not understood, but sometimes it's thought to be environment, sometimes it's thought to be because of genetic factors. So still a lot is not understood about this. And this is what happens in someone who has insulin resistance. Of course, insulin resistance causes concomitant production of more insulin. The insulin that is produced will result into hyperinsulinemia. The hyperinsulinemia is the one that actually provokes the typical features of polycystic ovaries. I think this flow chart will actually discuss it much clearer. If you have hyperinsulinemia, it actually alters the pulsatile release of the GnRH. So this means that it favors more production of LH compared to FSH. And if you look at the function, or the primary function of LH, of course, is to cause ovulation, but more importantly, it also causes the thecal cells within the ovary, within the follicles, to produce androgens. And then this androgen is converted to estrogen by aromatization that is geared by the FSH. If you produce more LH, that means you produce more androgens by the ovaries. Not all the androgens that are produced will be converted to estrogen, and that means that you start having excess androgen. So it is thought that the excess androgen is the one that actually drive the pathophysiological signs of polycystic ovarian syndrome. Here it actually causes abnormal lipid profile, and then it also causes excess adipose tissues. When you produce a lot of androgen, you've seen central obesity, and the central obesity will actually worsen the insulin resistance, and this will worsening insulin resistance. That means it gives another feedback to FSH and LH here through the hypothalamus. So this is how the whole cycles of this will occur. And because you have too much androgens within the ovaries, the follicles are not growing to maturity. So most of the follicles are getting arrested, and this will actually result into an ovulation. The chronic anovulation is a steady state that will be, and as you do that, as you have no ovulation, you're not producing progesterone. And then when you have no progesterone, you have unopposed action of estrogen on the endometrium, leading to irregular bleeding. Of course, the excess androgens that are produced by the thecal cells as a result of too much LH leads to asceticism. So this will cause that. The follicles that does not reach maturity will actually keep accumulating within the ovarian theca. And then that means that you actually have increased ovarian volume. And this, because of the follicular atresia, they are arrested. So that will actually cause the typical polycystic ovarian morphology that you see on ultrasound scan. How do we make diagnosis of polycystic ovarian syndrome? We need to look at the criteria that is used. The most commonly used criteria is actually the Rotterdam criteria that was formed in 2003-2004. In using the Rotterdam criteria, you need 2 out of these 3 items. You either need hyperandrogenism, or if someone has oligo or amenorrhea, or polycystic ovarian syndrome. So if you have hyperandrogenism with oligo or amenorrhea, they already have polycystic ovarian syndrome. But for you to make a diagnosis using this criteria, you may need to actually rule out other endocrine anomalies that cause maybe an ovulation. So you may need to look at maybe thyroid disorders if it is there, look at congenital adrenal hyperplasia if it is there. You need to rule out those conditions before you actually commit yourself. So you either meet this and then rule out the other anovulation. It's important. So it's not necessary to do ultrasound scan. Many times people say, there's no polycystic ovarian syndrome. No, using Rotterdam criteria, you don't need an ultrasound scan so long as you have met the first 2 criteria. This polycystic ovarian morphology should be cautious when you're using it on women in adolescent, young women. You need to be cautious. Just for comparison, the other criteria, they are more strict. The NIH criteria of 1990 and then the Androgen Excess PCOS Society of 2009, you could actually look at it and just for comparison purposes. How do we diagnose hyperandrogenism or hyperandrogenesis? Now, this can be clinical. That means that if it is hyperandrogenesis, you just need to look at acne, alopecia, or asceticism. Asceticism, you score it using the criteria that is used for scoring asceticism. That is the Galway, Ferryman-Galway criteria. You use that to score asceticism. It may not be necessary for you to remember at this stage. In adolescents, the clinical findings must be severe for you to have this. Sometimes you find some alopecia or something like that. So you need to be cautious when you're making a diagnosis. Laboratory criteria. How do you make a laboratory diagnosis? Of course, you need to look at the free testosterone, the free androgen index, and then they calculated by available testosterone. So this would actually do that. Also, you may need to look at androstenedione or dihydroepiandrosterone sulfate. If it is total or free testosterone are not elevated. So sometimes when this is not elevated, you should not give up. Still can do this. But of course, most of the lab tests do not do this, so it's a bit tedious to do that. Diagnosis of anovulation. When you have irregular menstrual cycles, you actually just need to consider PCOS. If it is irregular, of course, in the first 1 to 3 years post-menarche, you actually have very unpredictable periods, but this normally stabilizes with time. So for you to make a diagnosis of PCOS, to make a diagnosis of anovulation or oligo-ovulation, you should actually have less than 8 cycles in a year. So considering less than 8 cycles in a year is important. Or if a woman has less than 21 day cycle, that's also a sign of anovulation. Or they have more than 35 day cycle. So those are the criteria you use for making diagnosis of anovulation or oligo-ovulation. This is if you look at these laparoscopic pictures, it shows how polycystic ovarian morphology looks like when you're seeing it on laparoscopy. How do you make a diagnosis of polycystic ovarian morphology? In the first 8 years after menarche, it's normally the ovarian volume is high, and then there are a lot of follicular activities, high incidence of multifollicular ovaries. So these are not signs of polycystic ovaries. So you need to be very careful at that time. And you may also need to do a transvaginal approach. A higher probe transducer is better. Okay. Normally you need to count the current threshold is actually 12 follicles. 12 follicles. You need to consider 12 follicles. But when you use an 8 megahertz transducer, you can actually, the threshold is actually 20 follicles. Or if you cannot count the follicles, you just document the ovarian volume. The ovaries 8 years and above post-menarche is normally not supposed to exceed 10 cc. So any ovaries more than 10 cc or more is actually a sign of polycystic ovaries. Already said, you need to consider other things. It's a multi-systemic disorder. You may need to consider increased risk of metabolic syndrome, look at the blood pressure, BMI, and then the waist circumference. You may need also to look at additional signs of insulin resistance and hyperandrogenism, like acne, asceticism. You may also need to consider looking at other things that can cause anovulation, like we already talked about it earlier. The incidence is quite common, depending on the criteria. 4 to 6 when you're using NIH criteria, but it can be up to actually 10%, 5 to 10% when you're using the Rotterdam criteria. This is actually increasing because of change in the lifestyle. It is the most common cause of anovulation, accounting to 25% of anovulatory disorders in women. You need to consider the differential diagnosis of this can be non-classic congenital adrenal hyperplasia that I talked about earlier. It could also be because of other endocrine disorder, like maybe non-classic, maybe you need to screen them for that. It could also be genetic. You need to also consider that. What investigation do you need to do? We already talked about ultrasound scanning to look at that, and that's how the polycystic ovarian morphology. See at the periphery, there is polycystic ovaries, and this is what they typically define as pearl appearance, like a rosary appearing on your neck. You put pearl on your neck. So that's how you, and these are the laboratory tests, and they're expected results that you see. The management, you need to set a goal of management. Could be because a woman has a menstrual disorder, you need to actually work on that. You may also be targeting people who have asceticism, may actually have infertility. Of course, the metabolic syndrome in life resulting into problems, you may also need to consider that when you're managing this. So it should be a multidisciplinary management. The physicians come to manage their X syndrome, and then the gynecologists come to manage their infertility and menstrual disorders, and also the dermatologists we need to consider. We also need to consider what? The asceticism. So it should be a multidisciplinary approach. The management can be divided into 3 categories. Could be surgical, pharmacological, or non-medical, non-pharmacological. But of course, the non-pharmacological and pharmacological are the first line of treatment, and then surgical should be reserved for patients who actually do not respond to the initial one. The non-pharmacological methods of management, you could actually consider weight loss. A weight loss of more than 5% of previous weight alone is beneficial in mild asceticism, so it will actually help to reduce the asceticism. So weight loss is very important. Lifestyle changes, you may actually need to change, maybe stop smoking, stop eating a lot of carbohydrates. So you actually help to manage your conditions. The pharmacological management could be in a number of dimensions. This depends on what you're treating. Normally, for you to achieve with PCOS, you need to set your goal. Setting goal is very important. You may need to consider oral contraceptive pills. This is very vital because it helps to produce more sex hormone binding globulins that binds the androgens, the excess androgens. So it improves. You also consider other oral contraceptives like cyproterone acetate, and then maybe also need to look at and then combine with spironolactone, which and then also 5-alpha reductase to lessen the testosterone production, testosterone production. You may also need to consider ketoconazole, especially if you want to reduce the androgen levels. As I said, surgery is normally reserved for the last the cases that have failed. When you actually maybe fear ovarian hyperstimulation or syndrome, or infertile women not responding to current treatment, or they have had pregnancy losses, you may actually need to consider laparoscopic drilling of the ovaries, or you can also consider doing open laparotomy in a center that does not have laparoscopy. The world is turning towards minimal invasive surgery, so you could consider doing that. Electrocautery can also be used to do that. We actually do in our center, in Gulu Hospital and in private practice, we actually do cautery, and this will help to remove the too much androgen excess that are there and improve the fertility for a year or so. You may also need to consider doing pelvic adhesion surgery if at all it is there. But normally polycystic ovarian syndrome does not cause pelvic adhesion surgery. For women who want to conceive, you may actually need to consider regularizing their period. And then you can consider also, if they do not want to conceive, you consider giving COCs. It actually makes them have regular period because of increasing these sex hormone binding globulins that binds the excess androgens that are in the blood. You may also need to consider giving progesterone-only pills. As you know, estrogen is produced, but progesterone is not produced because a woman is not ovulating. Insulin sensitizers are the mainstay of treatment now. Actually, the world has moved towards using metformin. I use metformin a lot in treating polycystic ovaries for many reasons. One, to help a woman conceive. Two, to prevent pregnancy losses brought about the PCOS itself. Three, it can also long-term treatment. It helps in reducing asceticism, acne, and then those dermatological presentation of PCOS. You could also consider giving your first-line treatment as letrozole, which is an aromatase inhibitor. You can actually consider this. You do 2.5 milligram daily for up to 5 cycles, and if they fail to get pregnant, you go up to 7.5 milligram per day. But it's expensive, but it's something that can be, it's not for everyone, but some people can really afford it. You could also consider doing clomiphene citrate, which is actually the traditional first-line treatment. The problem with clomiphene citrate is because of multifollicular ovulation, so you're more at an increased risk of getting twin or triplet. The other thing that also occurs is that you're more likely, at a higher dose, you're more likely going to get anti-estrogen. You may actually ovulate, a woman may ovulate, but because of the anti-estrogen property of clomiphene citrate, you actually have very unfavorable endometrium or unfavorable cervix. So the cervix cannot allow sperm to go anywhere. How do you treat asceticism? This is left for the dermatologist. You don't normally treat asceticism. Of course, risk for cardiovascular disorder may also need to be noted. You can also, if this fails, you may actually consider gonadotrophins. The gonadotrophins. This comes, the laparoscopic drilling also comes when this fails. So those are the second line intervention. The third line may actually be giving them an IVF. If they fail to get pregnant with the first and second line, you may consider giving an IVF for them. So basically, this is about polycystic ovaries. You may need to read more about it when you come. If you have any questions, if you have any concern, we will discuss while in the class. Thank you.